Hello, everyone, and welcome. This is Global Perspectives on Suicide. I'm Dennis Barnes, Executive Vice President and Chief Marketing Officer with RGA and Chief Executive Officer of RGAX. And we're glad that you could join us for this discussion. So around the globe, there are nearly 10 million suicides taken per year, resulting in roughly 800,000 deaths. And while the data is being closely monitored, the pandemic has played a role in the state of mental health, both globally, regionally, and locally. We've all felt it, including suicide. So why RGA and our interest in this? Well, there are conversations happening around the world and in our industry on the topic of mental health and suicide prevention. And not surprisingly, life and health insurers and reinsurers are at the top of that list of those conversations. And to better understand mortality impacts associated with suicide requires a deep understanding and analysis of the data that's available. And we couple that with a vigilance in tracking and incorporating new information from other sources, because we feel we have this responsibility to our clients and to society, and really as partners to the world, to facilitate these discussions and advocate for increased awareness around improving mental health and the intention of reducing suicide over time. Today, we're going to hear from a few of my colleagues, Scott Rushing, who's Vice President and Actuary. He's Head of Risk and Behavioral Science, and Erin Crump, who's Vice President, Business Initiatives. And they've been working very closely on this topic over the course of the last few years. Their intention is to share a global perspective, including suicide trends, initial results, and key risk factors related to the pandemic. And we're also going to hear from John MacBeth, CEO of TryCycle, a partner of RGA, and a true warrior when it comes to the topic of suicide prevention, specifically in the Canadian Indigenous youth community. Now, if you have questions during the presentation, please submit them. If we aren't able to answer them during the Q&A, we'll be sure to reach out following the webinar. But I'd like to remind you it's September, which is a very important month on this topic. It's Suicide Prevention Month in North America. September 10th was World Suicide Prevention Day around the world. And so there's really no better time for us to be addressing this topic. So with that, I'd like to turn things over to Scott to kick them off with some insights.
Thank you, Dennis. Yes, my name is Scott Rushing, and I'm an actuary at RGA. I'm also a leader in our global data and analytics team. And our presentation today is on the topic of suicide. Suicide's a very complex topic, but it's certainly one that's important to our industry. Our presentation today is split into three sections. First, I'm going to talk about population data and trends leading up to the pandemic. Next, we'll look at a few studies during the pandemic, including one study that RGA worked on with the industry. And for the final section, I'll pass it back over to Erin, and she will cover suicide risk factors and further explore the impact of the pandemic. All right, so as I mentioned, I'd like to start with population data leading up to the pandemic. I'm going to focus on select countries, and these are many of the top insurance markets around the world. So this first chart here shows age standardized deaths for 9 different countries. Again, these are the top insurance markets around the world. It shows the results for the past 30 years for suicide. And there's a few things to notice here. First of all, as compared to like medical rates of death, there's a lot more variation in suicide rates, not only in the absolute difference, but the movement up and down for suicide rates due to trends. Second, there's a lot of underreporting when it comes to suicide. There's some countries such as China or India who famously have sketchy information. Some countries consider suicide a religious crime or illegal. A lot of countries, there's concerns over insurance policies and the language and So coding something as suicide has implications. And finally, it does take time to rule out accidental deaths or homicides. And so sometimes countries are very slow to report official suicide statistics. All right, so next up, we have a chart, and this shows male to female ratios by country. So all of these are age standardized, so you can compare from one country to another. But the key takeaways here are that the male to female ratio does vary a lot by country. So for an example, the US has males dying at 3.4 times that of females. But if you look at this by age, it's actually 9 or 10 times that of females for the oldest males. For China, women actually have a higher crude rate than men, but since this graph here is age standardized, it actually looks like the males are higher. Another takeaway here is when attempting suicide, the chosen method plays a big part in the outcome. And so we'll talk a little bit more about this on the next slide, but in the US, for instance, the females attempt suicide 2 to 4 times that of males, but the males die at about 3.5 times the rate of females. So there's a big variation in this across countries and across ages. And as we'll look at the next slide, the males typically use more lethal methods. Males are less likely to seek out help and that sort of thing. So the result is a higher number of men than women completing suicide. All right, this next slide, this looks at top methods across the different countries. And there's a lot of different observations from this slide. This is a complicated slide. The first thing you'll notice is hanging is extremely common around the world. It's the primary method of suicide in most countries. In the US, firearms come in number 1 for males and very, very close to number 1 for females. Guns make up about 5% of suicide attempts, but they make up 50% of the deaths. So they're extremely lethal. Pesticide suicides is very common in rural parts of the world, especially in Asia, Latin America, Portugal, and some countries. Pesticides are very common. Charcoal burning is an emerging method of suicide. It's common in certain parts of Asia. It's basically suffocation by lighting charcoal and locking yourself in a room, so not a good way. Jumping is popular in small urban societies such as Hong Kong. It makes up about half the deaths in Hong Kong. Drugs are extremely common, but they're not very lethal. So, to be number 1 in some countries says a lot about the other methods or says a lot about the use of drugs. So they're very common in Canada, very common in the Nordic countries, the UK. And so really, when you look at a given country, age, sex combination, there's really 3 key elements that drive the trends that we saw on the other slides. It's number 1, what are the methods that are most easily available to people? Many suicides are extremely impulsive, and a lot of it comes down to what's available to people. Number 2, what methods are socially acceptable? There are some countries where certain methods are not socially acceptable, believe it or not. So that drives trends as well. And third is how effective are the methods? So some of the top causes are not always the most popular, but they are the most fatal. For instance, guns, extremely effective in completing a suicide. Hanging and pesticides are also very effective. And really what we find in the statistics is these 3 methods, hanging, pesticides, and guns, really do drive the global trends that we see by country. Charcoal and jumping out of buildings, pretty effective, not quite as effective as the other 3. And then there's many other methods that people use that are not very effective. Overdose on drugs is only effective about 2% of the time. So moving on to the next slide. Let's see here. Yeah, so as I mentioned, I'd like to start looking at population data leading up to the pandemic. And part of that is the studies we did in the industry and some other studies, and then we can compare those baselines to what we see during the pandemic. So this will focus on results during the pandemic. First up, we have a study out of the UK. So this was published in The Lancet, and it focuses on the very early months of the pandemic, the first 4 months of the pandemic. So right away, it's got a limitation on the results, but it looks at the trend from the prior 12 to 15 months, and it compares it to the 4 months during the pandemic, at the beginning of the pandemic. And the results, as you can see on the graphic on the right, the dots to the left of the line indicate that they are falling below trend. So for many countries, we saw results below trend, even though everything suggested that all risk factors had been elevated. So depression, anxiety, suicidal thinking, all that has been elevated. For the most part, they were seeing across the board reduction in suicides. There are some challenges with this study. Mainly, it's a very short time period. There's some very low numbers here, which makes it difficult to stratify results for the authors to dig deeper into some of these results. But nonetheless, it shows reduction. The next study comes out of Japan, and this is similar. So you see against a trend line, you see that initially the blue indicates a decrease, but then the red indicates an increase. So it's a slightly longer time frame here, but it does show that even after that initial decrease, we do see an increase. So that's interesting. And finally, I'd like to focus on a collaborative project that the RGA worked on with the SOA, LIMRA, and TAI to look at industry results. So this is not population data. This is based on 31 insurance companies. The goal of this study was not necessarily to study suicide, but instead we were going to look at industry data and attempt to quantify the excess mortality that we saw during the pandemic. The result of this almost 2 years of work here, we've been going on probably 21 months, I guess the study's been going on. We have published about 6 or 7 papers. They're available on the SOA website. And one particular paper actually digs into cause of death. So like I said, most of these papers look at excess mortality during the pandemic, but one does dive into cause of death, which is what I'll talk about real quick here. So advance, please. All right, so this particular slide here does focus on suicides, and it focuses on one cohort of individuals. It shows the age standardized mortality rates. So let's see. So initially we can see the age standardized mortality rates leading up to the pandemic, up to 2019. And then we can draw a trend line through these rates. So for this particular cohort, males under 40, you draw the trend line and you extend the trend line into 2020 and 2021 to try to understand what suicides would have looked like. You then put a confidence interval around it, 95% confidence interval, and then you plot the age standardized results during the pandemic. And you can see that they came in significantly lower for that cohort during the pandemic, during first quarter of 2020 and 2021. And finally, moving on to the last slide here. This is actually similar information. So this is very similar information to what was shown on the previous slide. First thing you'll notice is there are no graphs. So instead of graphs, what I did was I put all cohorts on one slide. So instead of, you can see in the purple boxes there, that's what showed on the previous slide. But now we can see many other cohorts on one graph or on one chart. The blue numbers on the page are the numbers that are below trend, and the red numbers are those that are above trend. So there's a few takeaways here. First of all, the mortality rates, the standardized mortality rates do drift up by age, especially, you see this especially with males. You notice the rates are a lot higher for males. And if you look at the last column on the right, in each part of this chart, you notice that the proportion of total deaths fall quite a bit by age. And then finally, if you look at the red versus the blue, especially for males, you notice that nearly all quarters fall below trend. All the numbers there shown are blue. Whereas if you look at the females, you know, the patterns are a little less consistent, but a lot of numbers are blue there, showing results below trend. So that's a study we're working on. It's continuing. We'll probably continue it for another 6 months or so. What we find is the data trails a lot of, it takes time to develop cause of death. It takes time for companies to report data. So a lot of times we're a little bit behind in the reporting. So we'll continue this through the end of the calendar year, most likely. And with that, that wraps up my portion of the presentation. So I'd like to pass it over to Erin, and she's going to talk a little bit more about the risk factors involved in suicide and the impact of the pandemic. So thank you so much, and Erin.
Thank you very much, Scott. Now that we've reviewed some suicide data and trends leading up to the pandemic, as well as the data available so far during the pandemic, we recognize that the story around the full impact of the pandemic on suicide is still being told. To look ahead now, what I'd like to do is to dive into some of the risk factors for suicide and take a closer look at how the pandemic has impacted some of those risk factors. The list of risk factors for suicide is long and each one of them complex. The list you see here is based on a variety of studies from around the world, with some factors being higher or lower risk. Most people who have risk factors for suicide will not attempt suicide, and it is difficult to tell who will act on suicidal thoughts. Stressful life events such as the loss of a loved one and interpersonal stressors such as relationship issues may contribute to suicide risk, particularly when they occur alongside these risk factors. I won't go through each of the risk factors that you see here, but I do want to highlight a couple of them. The first being number 4, previous suicide attempts. The relationship between suicide attempts and completions is a complex one as well. Most people who die by suicide did not make a previous attempt, and most people who attempt suicide will not go on to complete suicide in the future. Still, a history of suicide attempts is one of the strongest risk factors for suicide. Approximately 7% of attempters do go on to complete suicide, which is a far higher proportion than the general public. Looking to number 7, access to means, and Scott touched on this briefly already. While some suicides are deliberate and involve very careful planning, many appear to involve little or no planning at all. Chronic underlying risk factors, such as those you see here, are also often present, but the acute period of heightened risk for suicide is often only minutes or hours long. In fact, in one study, it found that more than 70% of those attempting suicide had planned the event within an hour or less. So restrictions to lethal methods of suicide like guns can improve suicide rates in part because people may be less likely to contemplate or complete suicide if given more time to deliberate. A quick glance through the rest of the risk factors that you see here, and it's obvious that the pandemic has had a material impact on a number of them. Loneliness and isolation, unemployment, perhaps even chronic conditions with all of the unknowns around long COVID. Let's take a closer look now at the impact of the pandemic on a few of these risk factors. One of the risk factors for suicide is a history of mental illness or psychiatric disorder. According to the OECD, the COVID-19 crisis has led to a significant and unprecedented worsening of population mental health. Here you see data tracking the prevalence or symptoms of depression in early 2020, shown in light blue, and a year prior to 2020, shown in dark blue. The data consistently shows that rates of depression increased in 2020 compared to previous years. Similar results were observed in anxiety. In many countries around the world, prevalence of depression in early 2020 doubled or more than doubled that observed in prior years. Periods when the highest rates of mental distress were reported correlated with periods of intensifying COVID-19 deaths and strict confinement measures. The World Health Organization has also reported that in the first year of the pandemic, global prevalence of anxiety and depression increased by an estimated 25%. There is also a strong association between alcohol misuse, either chronic or acute, and suicidal thoughts, attempts, and deaths from suicide. Based on studies in multiple regions, approximately 1 in 4 deaths by suicide involve alcohol, either as the primary cause of or as present in the person's body at time of death. Alcohol use disorder is also the second most common mental health disorder in people who have died by suicide, and people experiencing suicidal ideation are 7 times as likely to attempt suicide when drinking heavily. So how does alcohol increase the risk of suicide? Well, it reduces fear and inhibition, it impairs our judgment and decision making, it increases impulsivity and aggression, and it changes our moods, often towards negative moods and emotions like sadness or despair. As stay-at-home orders began in the US in the early part of 2020, one market insights firm reported a 54% increase in year-over-year sales of alcohol for the week ending March 21st, 2020. Online sales increased by 262%. The data that you see on screen here shows comparisons before and during the pandemic in self-reported drinking behavior in a US population. The comparisons were made on a variety of factors: the number of days of alcohol use, the average number of drinks consumed in the past 30 days, the number of days of heavy drinking, and adverse consequences associated with alcohol use as measured by the short inventory of problems scale. Increases were observed in nearly every measure for nearly every age group. On average, alcohol was consumed 1 day more per month for 3 out of 4 adults, and women had even more significant increases in both days of heavy drinking and in adverse consequences related to alcohol consumption. Like alcohol use, problematic use of other substances, such as drugs, brings an elevated risk of suicidal thoughts, attempts, and deaths from suicide. And just like alcohol, the pandemic has had an impact on drug use. Data shows that there have been large increases in many kinds of drug use in the United States since the onset of the pandemic. Researchers have found increases in the number of positive drug screens ordered by health practitioners and legal systems. And in these reports, positive screens were measured in a variety of drugs: fentanyl, cocaine, heroin, and methamphetamines. In one study out of Canada on self-reported use, drug users reported using more, engaging in riskier drug use behaviors like reusing syringes or using alone, and some users even reported relapsing during the pandemic. The data that you see here shows the number of drug overdose fatalities by year. Opioid fatalities are shown in red, Non-opioid fatalities are shown in blue. Opioid-related deaths were on the rise for more than a decade before leveling off in 2018 and 2019. However, opioid-related deaths were much higher in 2020 than in previous years, with a peak in May of 2020 coinciding with social isolation measures early in the pandemic. While deaths from all opioid drug types peaked in May 2020, fentanyl and synthetic opioids experienced the largest spike, nearly doubling between January and May of 2020. It's important to note that this graph shows all drug overdose fatalities, which is not the same as suicides, as many overdoses are unintentional. About 5 to 7% of overdose deaths are recorded as intentional, but because it can be difficult to determine whether overdoses are in fact intentional, the actual numbers are likely even higher. However, this trend is quite alarming and important to monitor given the known connections between opioid and other substance use and suicide risk. And one final risk factor that we'd like to look at is occupation. Occupation can have an impact on suicide in a couple of different factors. First, the factors of the job itself. So the security of the job, the stress of the job, perhaps low-paying jobs, and that job's access to lethal means. So the ability to obtain things like medications or firearms through that job. While the link between occupation and suicide risk may be weaker for many occupations, certain occupations do present an elevated risk. And because we're discussing the impact of the pandemic, here we'll look at an occupation that was certainly significantly impacted by the pandemic: physicians. Physicians have a relatively high suicide rate compared to the general population. You know, they have high stress positions, they're consistently dealing with emotionally challenging cases, they have knowledge on effective suicide methods, and they have access to lethal means through medications. In fact, suicide is the only cause of mortality that's higher in physicians compared to non-physicians. And the pandemic has been an incredibly stressful time for physicians. On the right-hand side of the screen, you'll see results from a survey of more than 13,000 physicians in the US in 2020, all on the topic of burnout. Not surprisingly, physician-reported burnout increased in the first year of the pandemic, but perhaps more surprising was that it continued to increase into the second year, with more than half of physicians reporting even higher levels of burnout in 2021. In this year, physicians were trying to get back to work while dealing with reduced staff, the continued stress of COVID-19, and the anxiety of having to return kids to school amid the ongoing pandemic. This stress impacted their relationships with family and patients, as well as their mental health. This is just one example of how many of the impacts of the pandemic are still unfolding. As we've seen today, many factors impact the complex issue of suicide globally. While suicide is not the only indicator of the negative mental health effects of the pandemic, there is so far little evidence of an increase in the risk of suicide globally as a result of the pandemic. However, the story isn't over, and we need to continue monitoring this emerging data, particularly as the pandemic's full health and economic consequences continue to unfold. This will help us be alert to any increases in suicide or its underlying risk factors, and perhaps help us understand what has kept suicide rates down so far. And most importantly, any preventive measures put in place during the pandemic by governments, employers, insurers should be maintained to ensure people continue to be supported and to prevent any longer-term detrimental health impacts. And with that, I'd like to turn it over to John, who's going to talk about his company's work within suicide prevention in at-risk communities. John, over to you.
Thank you, Erin. My name is John MacBeth. I am the CEO and founder of TryCycle Data Systems. I wanted to thank RGA for taking this topic so seriously. It's an incredibly important area that we need to focus more in, and we are honored to be here today. TryCycle is a software and a solutions company. We are a Can-Am company. We're based internationally in Ottawa, Ontario, Canada, and our US base of operations is based in Hartford, Connecticut. Though we treat and serve all communities, we spend particular time with Canadian and American Indigenous communities, which are often severely underrepresented when data is being provided in these two very serious areas. In particular, what TryCycle likes to focus on is when we think of suicidal ideation, the kind of the first cousin to that is self-harm as well. So when we kind of look at these initiatives, we have to look at some of the behavioral manifestations that we see in self-harm attempts and what that's telling us about the potential for suicidal ideation down the line. As we've recently seen in the last month in Canada, in Saskatchewan province, we experienced the second worst mass murder in Canadian history when 28 people were stabbed by a couple of brothers that are experiencing a significant mental health event at the same time as they were experiencing substance use disorder issues as well, where 28 people were stabbed, 10 people were killed, 2 people are still in either critical care or on life support. Why is that important to us other than to identify the horrific nature of that issue? Is that there's typically a domino effect within the communities when you see these kind of tragedies. Suicide rates in First Nations communities are 3 times higher than in non-Indigenous communities. When we think of Indigenous, by the way, Indigenous to us is First Nations people, Métis people, and Inuit people, just for clarification there. The next 2 slides paint a pretty bleak picture, but I'm happy to bring news that there is hope, that there is things that are happening in Indigenous communities right now. We are starting to see a bit of a trend. Our data is a little skewed right now because the pandemic had a disproportionately negative impact on Indigenous communities. So the data that we're seeing right now is really just up until 2019. The challenge that we have here is we think that the numbers are going to be even worse when we actually go through the pandemic related data. But as I said, again, there is the prospect of hope. The next slide that I'm going to show you here is, I hope it doesn't come across as unadulterated name dropping, but this is where the hope begins. What we're seeing is an introduction where the private sector is actually starting to participate more actively in Indigenous communities. We're starting to see trends where Western medicine is being built into traditional healing methodologies. So we're building hybrid options where the best subject matter experts that we can get from Canadian or American institutions is being bonded with elders, youth engagement, gatekeepers, and groups like this. So it's no longer the sole domain of the public sector of federal, provincial, and state government. It's not only their burden anymore. In fact, we think that there is a tremendous business opportunity for the private sector to engage in Indigenous. One statistic that has got us quite excited is that in the province of Saskatchewan, which was one of the base jurisdictions that we're working in very closely, is that in Saskatchewan by 2035, it is expected that Indigenous populations will become the majority in that province. And that trend is going across American jurisdictions. What's a little bit different from Erin's excellent presentation was that in Indigenous communities, you start to see a little bit of a difference in kind of the contributing risk factors. After 400 years of colonial neglect Mistrust is by far the most important issue in Indigenous communities. Experimentation, pharmaceutical trials, that whole scenario has had a very negative impact on the idea of trust between Indigenous people and the government. Added to that, is of poverty and distance in access in particular. There's in Saskatchewan and Manitoba, we are not aware of a single Indigenous community that has specialty medicine on reservations. There are general practitioners, there's family practitioners, there are nurses, but there is never a psychiatrist, a psychologist that is on res that would be able to help these communities, again, that are disproportionately affected. What TryCycle has done, and we are a tool, not the tool, I really want to stress that, is that we've taken a very disruptive approach to the problem. And what we've tried to do in the most pragmatic way possible is to bridge these chasms in the care cycle. We have two platforms that we've built with our partners. So that would be the private sector, the public sector, and our Indigenous partners as well. Our Tetherall product is a client to clinician, it's a client or a patient engagement to a clinician, and it is designed as an early intervention tool. We call it a digital compassionate tether. And the idea behind this is to start to support those people that are in rural and remote communities in a way that allows us to take a reactive state and turn it into a proactive state. In the year and a half that we've been involved in a lot of these communities, we've seen 1,000 interventions in one community alone. And these are interventions that otherwise the practitioner would never know was needed. So think of it as a call to action. Anecdotally, in the last month, a practitioner received an alert. It was a data-based alert that came on of our patients. The clinician reacted to that, engaged in a call to action, got in their car, drove down to the person's house. When they knocked on the door, a person opened, and they found the patient sitting on their couch with a noose in their hands. 15 to 20 minutes, if we had lost that time, there's a good chance that that person would have acted on their suicidal ideation. So the compassion and the empathy of that practitioner to get up, get in their car, and to go and visit that patient with data, empowering them, may have saved that person's life. On the talking stick side, we identified that there is because of the mistrust, and in these types of scenarios, that we needed to create an anonymous environment that would allow people to kind of reach out. Whether we're looking at the comorbid factors of violence in the household, sexual trauma, anything right down from diabetes, which is having a physiological effect on people, that these are all contributing factors to some of these social determinants affecting suicidation and self-harm. We've hired 250 peer advocates with full-time managers and boots on the ground, and these people are active in the community to make sure that that there is support for people that self-identify at risk. And really what we're trying to do is, in the easiest way possible, is to take data and to turn that into dialogue. So really the magic is actually happening at the practitioner level. All we're doing is empowering that practitioner with information that they otherwise might not have, so that they can really quickly orientate a treatment pathway with that person, rather than that looking for a needle in a haystack. And typically that's manifest in a simple question that you would hear all the time when you go to a counseling session, when a practitioner might say, "Hey, how are you doing?" That's a really difficult question for a person that really doesn't know themselves how to orientate any of their kind of their personal issues. So if we can help the practitioner to orientate the questioning or in the engagement, that is going to help the downstream that downstream impact. So Tetherall, again, is all about we use an app, but really what we're trying to do is provide that practitioner with as much information as we possibly can in the soonest amount of time, and to protect that data at the same time via data sovereignty measures that are required in Indigenous communities. In our talking stick engagement. It's really about listening. We're training and educating people. Their only job is to listen. Their job is not to kind of provide alternatives, not to recommend treatment paths for base, but that is based on an invitation. So if our practitioners identify somebody at risk, we would invite them. Would you like some heightened support? If they say yes, we give them the name and the information of that person, and they then are able to kind of reach out and to engage with that person. And most importantly, what we're seeing here is, especially when you're dealing with marginalized communities, is to bring culture back into that environment. We're working on translating the app into 7 Indigenous language, which are the 7 most used languages in the province of Saskatchewan. And as we roll this out across Canada and into the United States, we will maintain that philosophy of bringing that kind of cultural sensitivity into the environment. Language is culture, culture is language, and this is a much better way of kind of proving to our users that this was designed for them, that it's not one of these one-size-fits-all applications that you just kind of pull off the shelf. And with that, again, with great honor, I thank you for allowing us to speak about what we're doing at TryCycle, and I hand it back to the moderator.
Wow. Thank you, John. That's incredibly powerful work you're doing, and we all appreciate it. And to all 3 of you, there's so many questions that I have, and that would probably take a few hours to answer. For time's sake, maybe I'll just kind of click through a few of them, and I'll start with you, Erin. You know, we've talked a lot today about the data and trends we're seeing around suicide prevention and the impacts of the pandemic. And some of this is still unknown or hard to quantify at this point. But I'd be curious on your perspective, like what's the easiest way for our carrier partners, for insurance companies, to show their support and drive more awareness around the importance of the topic and be involved?
Yeah, great question. Certainly it's as you've seen, it's a complex topic. And so there probably, aren't any easy solutions, but a number of things come to mind. So I think, first, we have access to data, information, knowledge on this topic. And I think knowledge is power. So to the extent that we can share our knowledge, participate in studies such as the one Scott highlighted, the more we know, the more we understand about this complex topic, the more that we can reduce barriers and create actual solutions. The other thing that comes to mind is really thinking through, best practices to reduce stigma on this topic across all policyholder or customer interactions. So things like the language used on the topic, when was the last time we looked at our websites or our call center scripting around this topic of suicide? Do our call center folks, particularly during the pandemic, do they know what to say and how to handle a situation when someone calls in asking about the suicide exclusion in their life insurance policy, right? How do we talk about that exclusion? Just for example, if you Google the topic of suicide in my country, a suicide prevention hotline comes up. But if you Google suicide exclusion, it goes right to, carrier websites on that, the nature of the suicide exclusion, rather than redirecting the user to useful resources on the topic of suicide. If you look at the claims process, an entire family and a community is impacted when someone completes a suicide, as John highlighted. So what does that claim process look like for a suicide claim? And are there resources that we can direct beneficiaries to, and ways that we can support those beneficiaries better through that process? And then, of course, we're in the business of creating products to support members. So, really thinking through that list of risk factors and to what extent can we incorporate those into wellness programs, policyholder services embedded in the products that we write to really hopefully move the needle longer term on suicide.
Yeah, thanks, Erin. Great suggestions. And, as you kind of at the beginning of that spoke about some of the unique data and insights we might have because of the industry, Scott, it really leads me to follow up with something as you were sharing some of the data and insights, which were just remarkable. I'm curious if it's possible that the more recent data is starting to suggest an increase in suicide. I know you were able to kind of really pinpoint and lock down through a certain time period, but you're still accumulating information and going to keep measuring. Anything you're observing and the data that you're receiving as it's coming in?
Yeah, sure. Certainly the UK study and the Japan study both showed the very early months of the pandemic. And then our study that RGA did with the US industry focuses really on like the first 18 months of the pandemic. So yeah, it's definitely possible. You know, during my presentation, I did mention a lag in reporting. You know, it does take time for claims to come into insurance companies, for the insurance companies to process the data, for insurance companies to report it to for study purposes, for us to do the study, for us to do the publication. It all takes time. So there is a natural lag. It especially takes time though to get cause of death correct in studies. So there's always an additional lag when we try to do cause of death studies. So like I said, the most recent study goes through about third quarter of 2021, so about 18 months into the pandemic. And we found that the industry data is just not very reliable beyond that. With that said, we do plan to continue the study. We do plan to go through the end of the year, probably bringing the study timeline to early 2022 or something. So we'll, you know, you add 9 months onto that, maybe by the end of 2022, we'll be able to study for the beginning of 2022. And it is possible that we'll see a reverse in the trends, but at the moment, yeah, this is what we're seeing.
Thanks, Scott. Well, we'll stay tuned for more. Appreciate that.
Yeah, take a look at the SOA website. Like all the publications will come out on the SOA website.
Okay, excellent. And for those who are not in the US, that's the Society of Actuaries website that Scott's referencing. So I encourage you to take a look. And maybe, John, I think it's fitting I ask you the last question because you're on the front lines doing the hard work. We're just in analyzing mode and looking at the data, and it's just remarkable what you're doing. Obviously, you've seen some positive outcomes and you're getting feedback that what you're doing is working. And certainly we want to continue to support that. So what can the private sector do to get more involved? How you showed a lot of logos and a lot of organizations that are stepping forward, and but there are many more out there. So what more can we do?
You know, Dennis, it's a great question. The first thing that I would recommend is for the private sector to understand it. There is a business opportunity to begin to work and to engage in Indigenous communities that I think it's been a blind spot for decades. We're starting to see these demographics with very, very high birth rates. When, you know, the non-Indigenous communities are kind of seeing stunted growth in these demographics, we're seeing a real surge in Indigenous communities, and that's a good thing. So there's nothing to apologize if you're looking at kind of a business opportunity to participate, because it's going to help. Looking at the challenge, which is incredibly complicated, the other presentations, like it kind of stops you in your tracks sometimes, and you kind of get that ice cream headache, and you say, well, where would I start? Which is that kind of that true north. Is that we look at it at a comorbid approach. Is not necessarily, we often look at the end as opposed to the means. What are the manifestations that got us to that point? And the more research that we do, it's a very diverse question and very diverse answers. So the private sector can bring their expertise to the conversation. For example, when we look at suicidal ideation and self-harm, you may have issues where, for example, Roche and Boehringer, pharmaceutical companies, are helping us with diabetes modules and to build heart attack and stroke. When we look at the University of Connecticut, and Bill and Melinda Gates, they're helping us build postpartum depression modules. When we look at the RGA Foundation, generously invested in a grief and loss module. Each and every one of these contribute to a kind of a mosaic of modules that allows us to customize the approach when we're identifying a treatment pathway for a potential patient. So I would welcome the private sector to kind of roll up their sleeves and look at this as a business opportunity where you're helping people at the same time.
Yeah, thank you. Appreciate that. And yeah, I think we all feel a connection to this topic and are looking for those avenues. So I appreciate that. And with that, I'd like to thank you, John and Scott and Erin, for presenting today. And I'd also like to say thank you to the IIS. It's been a great experience, and I hope it has been for everybody listening. We have a short survey that we kindly request you complete. If you scan the QR code with your camera on your smart device, you'll be able to dive right into that survey, give us some immediate feedback. And it's very important to us. It's how we continue to develop and improve and prioritize future content. And finally, I want to let everybody know a recording of the session will be available on the IIS website, and you'll receive an email following this session to that link. So with that, thank you to everyone for joining us today.